I'm Jerry Nelson, the interim chair at University of California Orthodontic Division. I produced this presentation for the attendees to the 2014 CareStream user group meeting. We've used the CareStream 9300C at UCSF for 4 years, taking just under 2,000 scans a year. So overall, I think a very good record both in the reliability and the backup. Here's the UCSF dental clinic that I graduated from in 1965. I was lucky to have a window chair that I could look out over the Golden Gate Bridge and the entry to the bay. It was really quite wonderful. About 10 years ago, we renovated our clinic, and this is what we have, 10 years old, but still functioning really quite well. What I want to do today is discuss the use of CBCT technology in an orthodontic practice, both the diagnostic value, the radiation exposure, the liability, and some on the economics of it. I want to review some research, both the research we've done and some research in the literature, and then show you a systematic approach to reviewing the CBCT. There's a bit of controversy now surrounding the use of CBCT in orthodontics, particularly on a routine basis. I just wanted to point out that this same controversy occurred when head films were first introduced. Broadbent, who did tons of research, took these films on children every single year of frontal and lateral until they were 21. And there was some controversy about it. And of course, the radiation exposure for those head films was, like 50 microsieverts. Now we're under 5 microsieverts. But it was a new thing, and it was an interesting technology that we've fully adopted in orthodontics. Broadbent was fascinating in that he also set up a system of orienting the models to the cephalograms so that you could really see what you're going and coordinate both the head film and the model setup. A lot of people are telling us what to do with these CBCTs. The American Dental Association, the American Association of Orthodontists, and British Orthodontic Society, and then the journals come out with articles telling us how to be careful, and the National Council on Radiation. So a lot of information. And what are we supposed to do with it is part of the question. Well, the research that's been done has mostly been done on adult phantoms. A phantom is a model like this that has sensors in it that measure the exposure that the patient might feel in different parts of the head, and the sensors are adjusted to coordinate like with the thyroid or the palate or whatever. Most of the research has been done with adult phantoms, which is not typically what we do. And basically we don't do research, we don't do our treatment the way the research is done, because the machines are set at full speed, they shoot a whole head, and we can moderate these things. We can adjust things to reduce the exposure. For example, the settings. We can take a smaller field of view. We don't have to take a view of the whole head. We do want a head film, and we can take a separate head film, which is very low exposure. The power can be controlled by the operator and the exposure time. So those are important controls. And then the hardware you happen to choose for your office should have all these modern features that are listed here. The one thing that many of the machines do not do is horizontal collimation, and I'm going to explain that in a later slide. But let's look at the field of view. This is one way to cut down on your exposure, and this is what we use. We use this 10 by 10 with the idea we're trying to get from condyle to chin. So in a small person, a 10 by 10 will do that. We take a 2D head film along with this. In a larger person, we really need the 11 by 17 in order to get the condyle in in place. So the horizontal collimation is another way that you can cut down the exposure. Now, all the machines will allow you to adjust the cylinder vertically. You can move the top down or the bottom up, and that way take a sort of wide column anywhere in the head. But many machines can't do the horizontal, where you can move the right end or the left end. And what that allows you to do is take the smallest field of view, this say a 5 by 5 centimeter, and orient it so you can look at just one quadrant, and or the third molar, or some specific area. So that means that the exposure you're doing is like a set of bite wings, but so much more informative. So the field of view and resolution is coordinated. In other words, if you reduce the field of view, you will reduce the, you'll increase the resolution. So, for example, the 10 by 10 I was telling you about is 0.183 millimeter size voxel. If we cut that in half to 5 by 5, then the resolution goes to 0.09, which means that the resolution's better, the voxel's smaller. It's just like the regular photopixel size. The smaller the better. So we've got this advice, we know something about it. How do we order a CBCT scan? When do we decide to do that? I think there's two options. First option is you just do a clinical exam, you do a history, and after you've looked at everything carefully, you decide, okay, I think we need just a pano, or I think we need a CBCT, or we need periapicals. Well, I can think of 11 reasons to do the CBCT. First one is delayed eruption. If a tooth doesn't grow in on schedule, there is a reason, and you need to figure out what the reason is, obviously. Usually it's a supernumerary, right? I think a CBCT is the best choice here, since any other image that you took, you'd have to take additional ones. And also, one supernumerary, maybe not, might be others. Another reason is mouth breathing. When I see a patient who is an obvious mouth breather, it's a red flag for me. There's so many new articles, dozens of articles, talking about the airway. And the reason it is because of the CBCTs that are taken now on a more routine basis, that we really know more about the airway. And the treatment planning has to take into account if a patient can't breathe through their nose, do we want to do some expansion to try and help that get better? Another reason, number 3, is ankylosis. I think when you have an ankylosed situation, the oral surgeon might have to be involved, and they're going to need some decent x-rays in order to know exactly what to do. So I would say avoid all the extra images that you might take and just take the CBCT. Asymmetry is another one. An asymmetry can occur anywhere from the eyes down to the chin. And so you need to figure out, okay, where is the problem? Is it going to require upper jaw surgery or just lower jaw surgery? Do we have to do some orthodontics prior? All those questions can be answered with adequate imagery. And the Pano-Ceph just cannot tell you the answer. Even Pano-Ceph and AP head film is not quite up to it. Some trauma, number 5. I think trauma is another reason to take a 3D x-ray, because while you might take a periapical and see that the tooth root itself is or is not fractured, but if there's an alveolar fracture, can you see that in a periapical or a pano? Not necessarily, but I do think with the CBCT you could take cross sections and really verify it. In our craniofacial patients, we have a very strong craniofacial department at UCSF, and CBCT is really what we prefer to take with these patients who are going to need bone grafting, may have some supernumerary missing teeth that need to be sorted out. So the 3D X-ray is definitely a necessity. Another one, number 7, multidisciplinary treatment. I think that in these cases where you're working with a periodontist and a prosthodontist, this is how you get the best communication and collaboration in order to plan the best treatment. I mean, this patient has missing teeth, has retained baby teeth, midline shift, asymmetry, lots of things going on that require good collaboration. Our orthognathic patients are almost all treatment planned using 3D x-rays because that's how we can really determine which jaws need to move, where, and when. For orthognathic planning, we do use the full head scan, so the patient is subjected to more exposure, but for good reason, and I think it really benefits the patient. Whenever I see a supernumerary, erupted supernumerary, I think, okay, is there another one up there? And I think then I want to take the 3D x-ray to verify that. And this patient actually does have another one. I'll show you it later. When I'm planning temporary anchorage devices, I like to have the CBCT. I want to really know what kind of space I have for the device. I want to know what the cortical plate looks like. I want to know what the distance from the buccal wall to the lingual wall of the alveolar process is, so I can know what size of TAD I can use. Am I limited to a 6 millimeter, or can I put an 8 or even 10 in there? And then the thin biotype patient. Now this may not be intuitive to you, but our research has shown that these kind of patients not only have thin gum tissue, but they also have thin alveolar housing and very little bone over the roots, and that's something I think you have to take into account. So if none of these conditions exist, I think you can in good conscience just do a 2D series and go from there. Of course, once you take the 2D series, you may discover that you're going to need to take a CBCT anyway. So that's the first option, is look for these particular 11 conditions that might tell you, yes, let's take a 3D x-ray. What's the second option? Well, the second option is just, I think, sort of more routinely take a 3D x-ray that is basically a 3D panoramic, and that take the 2D, since it's such a low exposure type of x-ray. Ours, you know, this new Carestream that we have is like under 5 microsieverts. A 7-pan, 2D 7-pan, are 25 microsieverts, so if you take a 7-pan and then you might need a periapical or some TMJ, you're going to get over the microsieverts that we use for the CBCT and lateral head film. And remember, every week we receive 200 microsieverts from the sky. And I think it's good to remind patients that that's just the norm. This is a very small exposure when you think of it. We've learned a number of things from our research at UCSF. And this is just a list I'm going to go through. We graduate 5 residents every year from our 3-year program, and they all do a master's project in craniofacial biology. And a master's thesis at UCSF, it's no joke. I mean, there's some world-class researchers there that are mentoring some of these research projects. A lot of our projects are with CBCT, and pretty much 30% of our theses in the last 5 years have been published in peer-reviewed journals, including the AJODO. The first one, accuracy. Scott Strataman was a resident for us, and he published an article, one of the very first articles on accuracy in CBCT. He put fiducials in some bones, then shot x-rays of them, and found that the linear and angular measurements are very, very accurate, very reliable. He's in Texas in his orthodontic practice that was started by his grandfather. I went and visited him in New Braunfels. It was very fun to see him. And then another accuracy article I really liked was this one, where they took some cadavers and took images first with soft tissue in place, then they took off the soft tissue and took some CBCTs, and then they simulated some dehiscence and took some CBCTs, and they found, and then they did this at different resolutions too. So with the 0.3 millimeter voxel size that we use, they found that the cortical bone would be 1 millimeter short of reality. So you see the CBCT, there could be a millimeter of bone there that you can't see. So basically, the CBCT underrepresents the cortical bone layer by one millimeter. So then superimposition is another thing that's happening with 3D X-rays and will become much more important in our treatment analyses as we go along. Andrew Harner, a 2005 graduate, published this article in 2009 that was really one of the first articles to study superimposition of craniofacial sets. And now there's just dozens of these articles. And one of our recent ones was done by Christian Salem, just published last year. He graduated in 2011, and this was a really neat article showing superimposition on the cranial base. The article was talking about retraction, en-masse retraction of the upper anterior teeth and the effects on the lip posture using TADs. But his system is good, very visual, it really is. Another area of research that has really piqued my interest is the the bone housing around the teeth and what happens during orthodontic treatment. And my buddy Jay Park, who's chair at A.T. Still University in Mesa, Arizona, he did this study showing that when you retract teeth, you retract upper anterior teeth, the bone on the lingual actually becomes quite reduced compared to where it was at the start. So this is something that's a little nerve-wracking, and we have to pay some attention. And our particular study with one of my residents, Na Huang, showed some important difference between low angle and high angle cases as far as the bone housing goes. If you want to move teeth labial or lingually, I think routine slices of the bone housing, both upper and lower, is a good thing. Anyway, Na showed that in the high angle cases, the amount of bone support around those lower incisors is limited, whereas in low angle cases, a little more leeway. Another study at UCSF by Cameron Nabadara, which he published a couple years after he graduated in 2009, was one of the first sort of studies of Airways, and he compared conventional head films and CBCT and found that the conventional head films actually give you a pretty good sagittal view of the airway, but doesn't tell you very much about anything else. The volume, I mean, there may be some constrictions that you can't see that are not in the sagittal plane, that are in the frontal plane. It doesn't tell you too much about the nasal airway, which we can now do with CBCT. Another area, we've done some research on this, but this was not our project. That was in the AJODO last year, showing that during expansion, what happens to the buccal bone? Well, this was interesting because it showed that in slow expansion that you lose more buccal bone than you do with rapid. So rapid expansion actually results in less buccal bone loss. So there's another expansion study that we did with Dr. Kim. These are some patients in Korea. We kind of collaborated on this study, and this bone-borne expansion was interesting because it was supported by 4 implants, TADs, and which is more than other articles have done. Other articles with bone-borne expansions show no difference really between bone-borne and tooth-borne, but Dr. Kim's study showed that there was a difference. There was a lot less bone loss on the buccal, and the skeletal change was more also. The study's in press. I mean, it's not in the AJODO yet, but it will be later this year. Root angulation is another thing that's been looked at. Now, we know that panoramic images of the root angulations not so good. I mean, that's been shown by studies comparing skulls and then take a pano and compare the measurements. Well, we compared CBCT. Linda Young did this when she was a resident and found that the pano puts all the upper posterior roots too far distal, puts the upper anterior roots to the mesial. And in the lower arch, puts all the roots a little bit mesial of where they actually are. So we took the two x-rays and then she measured them physically on this model that has little fiducials in it. We take a progress x-ray to look at root positions, and we use the CBCT, and you might say, well, geez, why are you taking such high exposure? But actually we back off on the exposure. It's taken at about 9 months, and we take it at a 4 mil voxel, so it's a little less resolution, and the exposure to the patient is only about 20 microsieverts or less, so that's actually less than a panoramic, but the information is so much better. We'll see an image of that later. So that's 6 things we know, and there's a lot more. You know, that root resorption seen better, and that TAD, the best buccal sites, and so on. And we could look at research all day because more and more articles come out every month. But I wanted to talk about how do you use 3D x-rays in orthodontic diagnosis. Here's what we do at UCSF. We get the 2D head film, we get the 3D pano, we take photos, models, clinical exam, and history, and then our radiology technologist, Eddie Garcia, he puts together a series of images that, you know, they're static. He doesn't print them out. They're in our server, so they go into Dolphin so that we can easily look at them. And then he provides us with the DICOM series and the CareStream 3D software so that we can go through all the slices in all 3 planes of space. So that's the basic review of the records we do, and then we can assemble the problem list, the goals, and the treatment options. So these are the example of the photos that we would typically use, and then the intraoral photos, just as all of us do. And then these are the images that Eddie makes for us. He lays out these volumetrics on the top, takes a pano that has a 20 millimeter thickness to include all the teeth, where you get a view of the sinuses and the condyles, and then he takes the transaxial slices of the lower and upper anterior regions, and then 2 side 90-degree views of the condyles, so that we can look at the joint space, at the condyle cortical plate, and the status of the TMJ. And then we have our 2D head film, from which we can take the ordinary measurements that we all use, and then we also have an AP head film that comes out of the 3D series, and you can see it's not the full head, and you don't need the full head. You really need from eyes down in order to evaluate that symmetry. Then we've looked at all those static images, and now the resident goes through the 3D images in the CS software. So first thing he does is take the volumetric and sort of get it lined up by lining up the eye sockets, so that it's just a measure of symmetry if we can get the right and left eye sockets sort of basically superimposed. And then we can flip the image around and take a look at it, and that'll give us some idea of the asymmetry. You can see that the lower left mandible is kind of larger. Then we'll go through each of the 3 planes of space and just travel through. And as we travel through, we can move our pointer down to this area here, and that will, and then by running your little mouse wheel back and forth, you can really do very close and accurate and detailed movements. So we go through, we look at where the cervical stack is, try and get an idea on that. We look at the sinuses. We'll go through and look at the airway. Again, looking at the cervical bones to make sure that all looks pretty good. And you can go to your mouse wheel and adjust it for fine-tuning. And then we continue on and we go through the other sinus and see that it's got a mucus retention cyst in there. So a little glob of fluid. And, whoops, computer's jumping here. That should fix that. And then, as we go through, look at the other condyle, look at the joint space, cortical plate, and then we'll start looking through another plane space, the frontal slice, and we're just going through again, looking at the cervical bones briefly, and passing forward until we see the condyles to get another view of the condyles, looking for joint space and cortical issues and medullary bone, and then keep traveling through. We will again sort of pass through the sinuses and see another view of our mucus area, and then continue on through the anterior region. Then we can go down to the yellow line here on the lower right and start passing from bottom to top. And we'll go through the mandible and sort of looking at the airway at this point, and also watching our the cervical bone, the neck bones, and then until we come up to the condyle, we get another view of the condyle, and we can start seeing the sinuses here. And keep traveling through until we sort of get to the top of our imagery. There's the mucus cyst from another view. So that's going through the 3 planes of space. Then we go to our next image, which is, I just wanted to show you how the panoramic is traced. So we click that icon on the lower left over there, and then we can just draw a line through the arch in order to develop our panoramic. Now this line right now just has a 1 millimeter thickness, so it really doesn't get everything. So you have to go and open the thickness to maybe 20 millimeters so that you can really see everything you need to see. And then you can adjust all these little marks so that you get the best view of the condyle and everything else. And so once you get all these little red dots adjusted for the best undistorted view, then we can move to the next step. So I'm taking a few minutes here to get some adjustments. And every time I adjust it, I kind of look at the roots and the structures that I'm interested in to sort of make sure that it's the least distorted view of it. And I think, you know, as accurate as these things are, I will say going through the slices in the 3 planes of space is much more accurate. This panoramic is good, but it's not as good as you would like it to be. Then once you've identified everything, you can change the density to maybe get a little better view of it. And then another feature of the CS software I think that is pretty cool is the TMJ view, and so we go through that too to take a look at things, and what you do is just sort of mark the area where you want to look and orient that little crosshatch until you get the jaw joint oriented, and then you can go down and actually look at the volumetric, and even then you can change the coloration of it so that you really do get the whole view. So I think that's a really nice little portion of this software. I enjoy it. I think that it helps us a lot. So then what we do is we have all the information we need, then we set up the diagnosis, the goals, and our treatment plan much in the same way that probably everybody has a version of this in some way, but this is how we teach the residents to do it. So partway through treatment, we then take a progress CBCT. Now, you want to know if the roots are reasonably parallel. You want to know about root resorption. So this X-ray, which is actually less, well, it's less patient exposure than a pano would be. It gives us much better information because we can rotate this image around and look at the roots in all dimensions, and we can go through slices too. The resolution is about 0.4 millimeters, so it's not as good as the one we take at the beginning or the end. It's a 10 by 10, so it doesn't typically get the condyle in an adult or in a large teenager. We dial back the power to about 70 kVs, and the milliamps are 2, and the time is the shortest the Carestream will take, which is 6.2 seconds. And this is the kind of image you get. Now, are other orthodontic programs teaching 3D X-rays? And the answer is yes, they are. My friend Jay Park at A.T. Still University, Mesa, Arizona, they did a study on this. And by the way, Jay Park is now the editor of the PCSO Bulletin. It's a job that I did for 20 years. And if you want to go see the PCSO Bulletin, it's free. You just go to www.pcsortho.org, and it has some nice things. There's always a case report. There's always Earl's Pearls, which is now called Pacific Pearls because Earl kind of stopped doing it. And then there's Jerry's Gems, which is a practice management tip that I usually put in there. And, the problem with CBCT in the orthodontic programs is who sets the protocols for the use of the device. So the state law in Massachusetts, for example, only MDs can order a CBCT. So that's a barrier. I mean, if you need a CBCT, you have to go, okay, call the physician and have them order it. At the University of Washington, Greg Huang told me that their unit up there is owned by the radiology department, and they set the protocol for everything. At UCSF, we own our own Carestream, and we determine how it's used. So I think that if you're thinking of getting a CBCT at a university, I think if it's possible you can buy it yourself. That's the way to go. Anyway, Dr. Park's study showed that mostly the programs are using CBCT for impactions, craniofacial patients, and TMJ. Now, they didn't ask the question about orthognathic diagnosis and treatment planning, and we use it a lot for that too. So that was interesting. So most of the programs actually are using these things. These are West Coast programs. And then they did also ask the question about who reads them. And in the Western United States, they found that the radiologists are in the West Coast, that it's mostly the residents and the faculty who read these reports, and in the Eastern U.S., it's mostly radiologists. We're advised by the AO and ADA to educate ourselves adequately or use a radiologist. I think an important way to deal with this is avoid taking the large field CBCT. If you want to educate yourself, there's lots of ways to do it, but there's one book that I like by Dale Miles that has a whole set of dissections that are matched by the X-ray slices. So you see side by side, and one page is the dissection, and the other page is the slice in the same area. So this is really a very useful book. And then there's a YouTube by Ryan Kazemi, who's a radiologist in DC, and if you just Google reading CBCT images, you'll come up with it, and he takes you through all the slices and shows you all sorts of incidental findings. Now, incidental findings, that's an important phrase because that's what we need. We're used to looking at root positions, supernumeraries, missing teeth, whatever, and ankylosis, but Incidental findings are the things that we're not used to looking at. And if you put incidental findings into a Google search, you come up with 10 pages. If you put incidental findings with CBCT, that is, 10 pages of various sites that you can go look at. So I think it's important. Ludlow, who has done a ton of research on patient exposure, also has done some on incidental findings and found that airway, calcifications, and bone and TMJ, that's really the most of it. And I think airway is, let's look at some of those incidental findings. I've got a collection here. One of the most common, I think, is sinusitis, which could result in thickening or fluid retention. And sometimes it's associated with a calcification called an anthrolith. And it may come from an inhaled particle that then attracts precipitation. If it's small, it probably doesn't do anything. If the larger ones can irritate and cause inflammation. Another fairly common one, actually very common one, is concha bullosa, and it's a pneumatized cavity in the concha. Now, almost half the population has this, so it's almost normal, but if it gets really big, it can cause some problems. It can cause a deviated septum, for example. Is it associated with fluid retention in the sinus? Yes, it seems to be, but not seriously. So some include mucus retention. Another, and I'm going to the less common ones. This is another one that happens, is that the stylohyoid ligament becomes calcified, and these things can cause pain. The patient turns their head. It can cause a sore throat or even tinnitus. It's pretty rare, but we've seen it in our patients at UCSF. And it can actually, weirdly, even affect the carotid artery and press against it. So it's an important finding, but not one that you're likely to see in the teenagers. Another one, now this one is a common one. This range of percentages, this was a systematic review, so the range of percentages is in regard to the variety of articles that were considered. One thing I found out about deviated septums is that it can be associated to trauma, like a baseball in the face, or even compression during childbirth. So that's an interesting etiology of deviated septums. It also can be associated with Marfan syndrome, which is a connective disorder that has a peculiar collapsed maxilla and other kinds of morphology, and then things go with it: snoring, mouth breathing, loss of sense of smell. TMJ, there's lots of things that we are finding in the TMJ, and why worry about the TMJ? Well, we have to. There's nothing like informing before you perform. We can now warn a patient that the jaw joint's compromised, and there might be some symptoms as we proceed with orthodontic treatment that's not even related to orthodontic treatment. The problem was there at the beginning. Also, when we look at the TMJ, we can catch a COCR discrepancy. If the jaw joint space doesn't look right, it may be because the condyle is displaced. David Hatcher is one of our faculty at UCSF, and he originated this sort of standard, this diagnostics chart, which I think is really very helpful. The normal being up top on the left has a normal cortical plate, normal density of the medullary bone, and a normal shape. And whereas you go to the sclerotic one, and the medullary bone is a little bit thick and dense, and then you see the flattening. Well, we see flattening all the time and tend not to worry about it too much, but it's something that we can tell the patient that this is not completely normal, so we'll keep an eye on it. When I see the next one, erosion, when I see a loss of cortical plate, that's a patient I'm not actually going to start orthodontic treatment on until that repairs itself. I might refer them to the oral surgeon to monitor too. The Osteophytes or the beaking, which is second to last layer, I'm not too worried about, but again, warn the patient. And then subchondral cysts certainly is something that we do want to pay attention to and refer the patient. Okay, let's look at a couple less common cardiac artery inclusions. Calcium deposit in the artery, that's a marker for cardiac disease. And so with some of your adult patients, if you see it, I think this is an important thing to take note of. The calcification reduces the elasticity in the arterial wall. It is also associated with Marfan syndrome. And by the way, Abraham Lincoln had Marfan syndrome, which is typically associated with this kind of occlusion, very collapsed maxilla. Another less common, salivary gland calcifications. This sialolithiasis can hurt during meals, and it could be associated with chronic dehydration too. And even less common, maybe, oh, where did that implant go? And here it is traveling into the sinus. And then finally, Mom thought Charlie had lost his marbles, but we were able to show, no, he still has them. So we have supernumerary teeth is another thing that we are very concerned with. CBT is often used to plan treatment for that. And it just happens. So what is our liability when we order a CBCT? Well, are we staying within the standard of care? Well, the easiest way to, the shortest, most concise phrase I've ever heard for the standard of care is the level of knowledge, skill, and care of a reasonable dentist. We're not really obligated, we are obligated not to harm our patients, and one way of harming a patient is delaying the diagnosis. If we don't have adequate records and the diagnosis is delayed because we didn't see something, I think that's harm. We're responsible to diagnose disease that falls within the scope of our license, and that means all the disease or lesions in the jaws and related structure. And then once a lesion's noted, either you diagnose or you refer. If the patient refuses to take a CBCT, okay, then what's your choice? You can refuse to treat, or you can document that they have refused to take it and accept the risk. And I think when it comes to interpreting x-rays, you need to be competent. And so that means take some, and the AAO says, take accredited continuing education to maintain your competence. And attend to legal responsibilities in terms of don't overexpose the patients and provide proper informed consent. And then consent includes what the x-ray is, what it's doing, and what the risks are, or includes what the risks are if they're not taking your advice and getting an x-ray. So here are the course code credits for this course. And I have a second portion of this Atlanta Users Group lecture, which you can also download or listen to. Thank you very much for this opportunity. I do appreciate being able to share what we're doing at UCSF.